this is sort of really an overview of myelodysplasia, and I sort of hope that we'll get through it in enough time to leave ourselves plenty of time for questions at the end. So myelodysplasia is an abnormal development of blood cells in the bone marrow, causing low blood counts. So the way I explain it to people is that it's a bit like the machinery's broken. So all the elements are there to make blood, but there's nothing coming out the other end of the factory. The factory's working overtime, and there's often plenty of cells in the bone marrow, but not many mature cells actually coming out into the blood. So that's one problem that it causes. It causes problems with low red cells causing anemia, low white cells causing infections, low platelets causing bleeding, and then in some people a predisposition to leukemia, although that varies a lot according to what type of myelodysplasia it is. The cells that are affected in myelodysplasia are really all of the bone marrow cells. So you can see down in this diagram down the bottom is sort of the mature blood cells. So this is the red cell, these different sorts of white cells, these are the platelets over here. Also, no, that's not platelets. These are platelets over here, and but all of the precursors are also affected. So it's really a disorder of the cells, the immature precursors in the cell, in the bone marrow, which then affect all of their offspring. It's relatively common, but much more common as you get older, and so it's very uncommon in people who are younger than around about, say, 50. Pretty uncommon to get it in people in their 40s and 30s and 20s, but much more common as you get older. I couldn't find a good graph of that, but this is just to show you what happens in acute myeloid leukemia, and really you can see the incidence is low, and then you get to this age and it starts to rapidly climb. And really this is exactly mirrored by myelodysplasia. So myelodysplasia is similar, very, very low incidence, and then sort of increasing as through aging. It's pretty much impossible to tell in an individual patient what the causes of myelodysplasia are. Most people, there's no identifiable cause, so we're not able to identify any exposure to radiation or chemotherapy drugs or benzene, or which are sort of known causes of myelodysplasia. And so for most people it's just bad luck, and like other cancers and precancerous conditions, it's just due to random genetic events within the bone marrow cells as they're dividing, and those random genetic events cause mutations within the cells which just help them escape the body's controls, and if you get enough of those mutations, and then then the body has very little control over the division of those cells. Sometimes it's hereditary. Patients with Down syndrome have a higher incidence of myelodysplasia, but very, very rarely, really. And so, as I said, the majority are still idiopathic, which just means we can't really identify a particular cause. Now, we make the diagnosis. The diagnosis is actually often relatively easy, even from just the peripheral blood, but in almost all cases we'll need a bone marrow to both confirm the diagnosis and to tell how severe it is. And these are just some of the abnormalities we look at in the bone marrow. This is a normal white cell here, and some sort of slightly squiffy white cell, and then very, very squiffy white cell on the right. This is a normal red cell precursor, and just abnormal red cells precursors here, and normal platelet precursors and very abnormal precursors here, and they're the sorts of things that we look at in the bone marrow. So most of the diagnosis is actually made by looking at just the structure of the cells under the microscope, but we can also help the diagnosis along by looking at the cytogenetics. So the cytogenetics are sort of the makeup of the genes. So this is a cytogenetic panel. So you usually have one chromosome 1 from your mum, chromosome 1 from your dad, 1 chromosome 2 from your mum, 1 from your dad, and these chromosomes contain all the genetic material. This is actually an abnormal thing. It's got 321s, which is a Down syndrome picture, but it's just to show you the chromosomes and the fact that we can look for particular genetic abnormalities that are associated with myelodysplasia within the bone marrow cells. So these aren't things that you've actually inherited from your mum or dad. We're actually looking at these mutations within these chromosomes that have been inherited that have been acquired in the bone marrow cells. It's not something that you've actually inherited from your parents, the predisposition to myelodysplasia in the majority of cases. So myelodysplasia has lots of long and relatively confusing names. Excuse me. So all of these are just various different types of myelodysplasia. So they keep getting changed every few years too, which makes it more difficult. But there's refractory anemia with ring sideroblasts, so you can read through all the different types there. And then some of them that are really not even considered myelodysplasia anymore, that are sort of in an overlap group called myeloproliferative myelodysplastic syndromes. And basically, in some ways they add more confusion than anything, but the reason why we separate them out is that there may be a different cause of the different types that present with either different types of cells being low or with an increase of very immature cells within the bone marrow. And also these different classifications can also affect the outcome. So this is in one particular series, so don't worry too much about the exact figures, but this is just an example to show that, if in this series, the group that had refractory anemia with excess blast 2 only had a median survival of about 12 months, whereas if you had a 5q minus myelodysplasia, then the median survival was more like 10 years with a bit of a spread in between. As I said, that's only one group, and this isn't, you don't know where on these curves any one patient lies. So there's some people who are right out here and surviving very well with what would otherwise be relatively poor risk myelodysplasia. In order to try and improve our ability to work out what the risk is of myelodysplasia progressing, and as I said before, it can either progress by causing lower blood counts or progressing by turning to an acute leukemia. Then there's different systems that are used to try and look at that. So this is the one that's been around for ages. This is the International Prognostic Scoring System, and it's based on the number of blasts, the immature cells in the bone marrow, the number of low blood counts, and then the cytogenetics, so particular cytogenetic abnormalities that either give you a better than average prognosis or a worse than average prognosis. And you can look at this and add up a scoring system and then use that to guide us in terms of the outcome. So you end up with something like this, where based on your score, you might either be in the low, intermediate 1, intermediate 2, or high risk group, and we can tell in each individual group then what the median survival. So median means for example, in the low risk group at 5.7 years, 50% of the people will have died, whereas 50% of the people will live longer than 5 years. And so in an individual patient, there's no ability to tell where you lie in this graph. So as I was saying before, if you're in the low risk group here, we don't know whether you're somebody who's up here or down here. So on an individual patient, it's not very helpful. But if we're trying to work out what to do with a patient group of 100 patients or 1,000 patients, then these sorts of prognostic systems can be useful. And then just a couple of years ago, this was revised to try and include a bit more information, about how bad the low blood counts were. So if they were only a little bit low, then it wasn't so bad, whereas if they were a lot lower, then you got sort of a worse score. And also to break up the bone marrow blasts a bit more and to look at more cytogenetic abnormalities. So you can see that this is a lot more complicated than the other system in terms of different types of cytogenetic abnormalities. Each one of these represents one abnormality. So this is an extra chromosome 8, this one's an extra chromosome 19, this one's one too few chromosome 7s. And so we can look at an individual patient and try and assign them in this group. So it just increases the accuracy of assigning them. But again, it's still just a ballpark guess of how a particular patient is going to fare. This is a picture then to show that there are other things that impact on the outcome in myelodysplasia. So the number of red cell transfusions you need does impact. So this is just another example showing that this top curve is for people who aren't getting any transfusions over a 4-week period, where the bottom curve is for somebody who's getting 4 units of red cells over a 4-week period, showing that also impacts on how well you do with the myelodysplasia. So the more transfusions you have, the worse the outcome. Not because transfusions are necessarily bad for you, but because they're a marker of more aggressive disease. Sorry, I think my computer's just struggling to keep up. There we go, onwards and upwards. So the next thing then is how do we go about treating people with myelodysplasia, and the vast majority really just get supportive care. And so really the majority of people fit into a better risk group, and in that group really there's not a lot of treatments that have been shown to improve the outcome, and so most patients just get supportive care, mostly with just blood transfusions as required. Some patients have very low platelet counts, and if they have bleeding, they need platelet transfusions. Some people, if they've had episodes of recurrent bleeding, might even get platelet transfusions as a preventive measure. Antibiotics are used in people who come in with infections due to a low white cell count. Occasionally we use white cell growth factors to help stimulate the white cells to stay up at a higher level if they are low. And I'll talk about it a little bit more later, but with multiple transfusions, our body doesn't have a very good way of getting rid of the iron that's contained in that transfusion. So sometimes we need to use iron binding medicine to try and prevent that iron accumulating. Some of the other treatments that are sometimes used for myelodysplasia, so intensive chemotherapy, this is more along the lines of how we would treat a young patient with acute myeloid leukemia, where it's up to 7 days of chemotherapy, which makes the blood counts go down very low, involves 4 to 5 weeks in hospital, and in the setting of myelodysplasia has a lower risk of achieving a complete remission, and also a lower duration of that remission, and up to 10 to 20% of patients will have trouble during that initial therapy because of nasty infections, because of the low white cell count. And so while this is sometimes considered in people who have a very aggressive course, we certainly don't consider it in very many people at all with myelodysplasia, because it does need very intensive therapy and really doesn't have any proven survival benefit. And so there's been no trial to show that if we, in 100 patients or 1,000 patients, that if we do this, we actually improve the outcome. The drug which is probably most used in patients with higher risk myelodysplasia is a drug called azacitidine or Vidaza. And that's a drug that's given for 7 days every 4 weeks. It's given by injection under the skin, so it's not into a vein, it's given under the skin. And the 7 days can be consecutive, but most places will do it with a break over the weekend, so it'll be given for 5 days 1 week and 2 the next, or sometimes 4 days 1 week and 3 the next, or something along those lines. Azacitidine's actually been around for many, many years and was used as a chemotherapy drug even right back in the 60s. But the doses that are used for myelodysplasia are so low that they're not really chemotherapy doses. It works by affecting the internal metabolism of some of the genes in the cell and switching some genes on and some genes off, and just helping the cells mature more appropriately. The thing that with Vidaza is it can take a long time to work, and so the median time to response is about 3 months, so you really have to take it for 3 months before you even start to expect any response. And a lot of patients don't respond really for up to 4, 5, or 6 months even, and so you really have to commit to about 6 months of therapy before you know whether it's working or not. Although it's only a very low dose, it can still cause low white cells and platelets, particularly during the first month or 2 of treatment, and so very often it can actually increase complications and side effects during that first month or 2. But in the long run, about 60% of patients will have an improvement in their blood counts, and some of those responses are very, maintained for a very long period of time. The median duration of response is about 15 months, but we certainly have patients who are out at 3, 4 years down the track with still very good responses in their blood counts. And it also has been shown to delay the time to progression to acute myeloid leukemia in patients who are at higher risk of progressing to leukemia. So this is just to show this in a graph, saying that in the trial, which compared azacitidine with just supportive care, that the azacitidine group didn't progress until, on average, until 24 months compared to 15 months in the group that just got best supportive care. And they looked at a whole lot of other things about time to AML or time to AML. So 45% of patients with azacitidine will become transfusion independent, won't need any more blood transfusions, versus only 11% with best supportive care. So you can see that there are some patients who do, for reasons that we don't understand well, sometimes have an improvement in their transfusion dependence over time, even without any specific myelodysplasia-directed therapy. And over time, even though the azacitidine was associated with more infections in the first cycle or 2, overall there was much less infections in the azacitidine group, because over time it improved the white cells in subsequent cycles. And not only do all comers improve by azacitidine, but in sort of more elderly patients do also improve with azacitidine compared to supportive care as well. And so there's not really any upper age limit for azacitidine. It's more dependent on whether patients are wanting to travel into hospital for 7 days every 4 weeks, because that's really the biggest downside of it, is that the drug is not stable for any length of time. It has to be given close to where it's made up, and so it really usually needs to be given in hospital, and so it's a trip into hospital for 7 days every 4 weeks. Sorry, I'll skip that. So this is looking at the sorts of side effects that can be caused by the azacitidine, and this is just in general groups. So blood and lymphatic disorders just talks about the low blood counts. Administration site disorders, it's relatively common to get pain, sort of redness and pain at the site where the azacitidine is injected in the stomach. And it can sometimes cause some diarrhea or sometimes some nausea. But you can see that that's much more common everything's much more common in the first couple of cycles and then becomes sort of less common as we progress through treatment. And similarly, if you just look at the blood counts, again, much more common in the first couple of cycles and then becoming less common as we progress through treatment. And this is what I was talking about before, saying that really you have to persist with treatment before you get response. So this is in all the people that responded, so not everybody does respond, but if you take all the people who responded, so 100% of patients eventually in this graph eventually respond, almost 90% of them will have responded by 6 cycles. So there's still another 10% that will respond beyond that. But you can see if you stop at only 2 cycles, then only half the people who are going to respond have responded by that time. And so you really don't want to stop this drug too early or abandon it too early and say it hasn't worked. It's something that you really need to persist with. And we generally recommend at least 6 cycles of treatment. And if there's a suggestion there might be a response at 6 months, we often sometimes even go for another cycle or 2 beyond that to see if there is really a response. And if there is a response, then the drug continues indefinitely until until that response stops. And this is just another way of looking at that. So that last curve was the time to the initial response. This is the time to the best response, and you can see that really the best response can take up to 12, 13 months to achieve. And so we're looking for some response early, but then a continued response over the next few months up until about 12 months, by which time most people have achieved their best response. So azacitidine works by this DNA methylation, so I wouldn't worry too much about that, but this is just to show that you need to keep giving it. So over time, if it starts to drop away and then you get more azacitidine, it comes up, starts to drop away, you get more azacitidine, come up. And so we know in people where we stop azacitidine that things tend to go back to where they were with the myelodysplasia relatively quickly thereafter. And so it is a drug that once we've started and we've seen a response, you pretty much have to continue monthly indefinitely. So moving on from azacitidine, there are a few other therapies that are considered in patients with myelodysplasia. Sometimes we look at suppressing the immune system, so that's done by a combination of horse antibodies, antibodies against the immune cells in the body, which are sort of raised, the antibodies are sort of raised in horses, and immune suppressive drugs. This is only for a particular type of myelodysplasia where the bone marrow is very empty, which is very uncommon. Most myelodysplasia is where the bone marrow is full of cells, but they're not coming out the other end. Sometimes we see where the bone marrow is pretty empty, and in that case we sometimes consider this, but the response to it is dependent on the age and the duration of prior transfusions. And so the older the patient and the more transfusions they've had, the less likely we are to respond to this immune suppressive therapy. And so really this is something that we, at a big centre like the PA, we would only use probably once every couple of years, so it's only in a very highly selected patient population. As I mentioned, sometimes we can use growth factors, so there's erythropoietin or darbepoietin are 2 red cell stimulating hormones. They have been improved red cell production in myelodysplasia, but only in, again, a very sort of selected population of patients. And in Australia, they're not really funded for this indication. So the only funding for these drugs in Australia are in patients who've got chronic renal impairment, chronic kidney disease. And so sometimes we'll be able to access it for those patients, but otherwise we're not really able to access these drugs as a treatment for low red cell count. As I mentioned, sometimes we would also use this white cell stimulating hormone in patients who've got very low white cells getting recurrent infections, but again, it's fairly strict criteria that have to be met before we're able to access those, and without government funding, they're quite expensive drugs to be considering sort of self-funding. The other drug which has been used for, again, a selection of patients with myelodysplasia is a drug called lenalidomide or Revlimid. And this is particularly in the group of patients where the cytogenetic disorder is this particular 5q deletion. So this is a deletion of one part of chromosome 5, and that's seen in about 25% of patients with myelodysplasia, but in a much lower proportion of patients where this is the only abnormality, and it really needs to be the only abnormality to have a good chance of responding to this drug, although sometimes we use it in patients where there's other abnormalities as well. And in patients where this is pretty much the only abnormality, then about 2/3 of the patients will become independent of transfusions using this Revlimid or lenalidomide, with a higher number that have a reduced need for transfusions, and that this reduction in transfusion requirement really persists. So the average duration is 2 years, and again, many patients we've got are out many years still responding to this drug without requiring any blood transfusions. And in the patients who do respond, then they respond not only by needing less transfusions, but also actually by that abnormal family of cells in the bone marrow that have the cytogenetic abnormality disappearing from the bone marrow. So it does actually attack the root cause of the disease in these particular patients. And lenalidomide is being tried in some settings in patients who don't have 5q-, and also there's some response there as well, although it's not really accessible outside of the setting of a trial for this. It is accessible in Australia on the PBS, again, for a select group of patients who have 5q- and are also heavily transfusion dependent. It's not available for all comers with 5q-. You need to show that you are needing a lot of blood transfusions as well. As I mentioned earlier, iron chelation is an iron-binding medicine which helps to get rid of the excess iron that accumulates in the body due to recurrent transfusions. There are no randomized trials to actually show that this is worth doing, but there's quite a lot of anecdotal evidence, if you like, where it does seem that groups of patients who've been treated with these drugs seem to do a bit better than groups of patients who haven't been treated with these drugs. And so most people would recommend that we consider these medicines to bind iron once patients have had about 20 bags of blood, or this marker of iron in the blood is over about 1,000 or 1,500. And the medicines with a drug called XJade usually, which is a dispersible tablet. It's a bit like sort of Aspro Clear or something like that, that are dispersed in water and just taken once daily. Obviously, if we've got a problem in the bone marrow, then one of the things that we could do is look to replace somebody's bone marrow with somebody else's bone marrow. And so this bone marrow or stem cell transplantation is sometimes considered. So really, most of the time these days we're using stem cells from other patients, as in the stem cells are the primitive cells that are collected from the blood, but sometimes we use bone marrow, which is really also a stem cell transplant. It's just using stem cells that are collected from the bone marrow rather than the blood. And there's multiple different types of people that we can consider for stem cell transplants. We can consider a patient's siblings. Each sibling has a 1/4 chance of being matched in the bone marrow. Sometimes we consider an extended family, but that's not commonly used because even, obviously your mum or your dad have only got half of your genetic material each, and likewise your kids have only got half of your genetic material each, and so it's unlikely that they're unlikely to be a good enough match. And there are multiple donors on bone marrow transplant registries around the world. and so there is a good chance of finding an unrelated donor. But so most people were actually able to find a donor for if we want to. The problem is that it's a very toxic procedure and isn't usually considered in most patients who have myelodysplasia. So I showed before the range of ages which are used in myelodysplasia, the range of ages that are affected by myelodysplasia, and you saw that most patients with myelodysplasia are over 70, and and really once you're over 70, we generally wouldn't consider using a bone marrow transplantation just because of the risks associated with it. So there's two different types of bone marrow or stem cell transplants. One is with a standard transplant where we use very high-dose chemotherapy and radiation therapy to wipe out somebody's bone marrow, and then we replace the bone marrow using somebody else's bone marrow. Really, that's got a very high death rate from the actual procedure, mostly related to infections, and that death rate increases a lot as patients get older, and that's where it starts to get to an age where the risks outweigh the benefits, and so really there is a cutoff of about 70 where it's no longer a feasible alternative, or for this standard transplant the cutoff's actually more like probably 55, 60. This is really just showing that the people who we consider a transplant in are those with high-risk disease. So this top curve is the curve I showed you before, just the people who aren't transplanted, and you can see that the low-risk patients do better than those with high-risk disease. The bottom curve here looks at patients who are transplanted. You can see what happens is that the low-risk and the intermediate 1-risk patients actually seem to do worse with a transplant, whereas the high-risk and the intermediate 2 patients seem to do better with a transplant. And so generally that's what we would look at, transplanting patients who are high risk or intermediate 2 if they're young enough for a transplant, and you know, that varies from patient to patient, but usually means younger than 65 or certainly 70 at the outside. We can sometimes now use reduced intensity transplants where instead of the big whack of chemotherapy to wipe out the bone marrow and replace somebody else's bone marrow, we can use just a lower dose of chemotherapy just to suppress the immunity enough to allow us to sneak in somebody else's bone marrow and then rely on that person's immune system, the donor's immune system, going to work and sort of taking over the rest of the bone marrow, and that has decreased toxicity of the transplant, but still is still a risky procedure.